All right. So once again, welcome to Charter School Capital's COVID-19 Exposing Myths and Facts for Charter School Leaders webinar today. Very excited to have Dr. Greg Poland with us. My name is Stuart Ellis. I am the co-founder and CEO of Charter School Capital. And given this time in the world, I'd say today's topic is probably something on the minds of all charter school leaders, and I'm honored to have Dr. Poland with us today from the Mayo Clinic. As we move through this, I'm gonna turn things over to Dr. Poland to really educate us on the coronavirus situation as he sees it, and frankly, I'm honored and quite humbled looking at his resume and excited that we can bring this kind of information to the charter school world. Dr. Poland, welcome.
All right, thank you very much, Stuart. I appreciate it. This is, of course, a very rapidly changing and dynamic situation. My intention is to share with you some of what we know that I think would be important to you in making decisions in your context, and then trying to leave plenty of time for Q&A. By way of background, I'm a professor of medicine and infectious diseases at the Mayo Clinic. I've been there 33 years, I think now. Distinguished investigator of the Mayo Clinic. I'm the editor for our professional journal Vaccine, and I had mentioned to Janet and Stuart that we helped found a charter school in Minnesota, and my son's a professional soccer player and coach in Europe, and when he is in off season, he actually coaches at our local charter school here. So we know a lot about charter schools, and we're thankful for them. Next slide.
Thank you. We in the movement really appreciate your support and personal involvement. And with that, why don't we get into it?
Well, I wanted to start just to frame things with a slide from a quote of a book Albert Camus wrote about a different pandemic, one that happened in the 1500s. And he said they fancied themselves free. No one will ever be free so long as there are pestilences. Next slide. So let's also talk about various virus infections. So it'd be interesting if we could do a poll. This is a virus that infected 30 million people, 500,000 of whom were so severely affected that they were hospitalized, caused 30,000 deaths, and actually over 100 deaths in children. And I'm curious what you think this virus is. I'll tell you what it is. It is the influenza virus in the last 4 months, just in the US. No one's panicking. We have a safe and effective vaccine that we can't talk people into using. So let's just frame that as we begin to talk about this. We look in the US, you see the column labeled influenza. That's influenza just in the US in the last handful of months. The right-hand column is SARS-CoV-2 just in the US in the last month or so. The most updated numbers, and they change constantly, is that there are 1,700 known cases in the US and 41 deaths. So 41 deaths versus 30,000 deaths. And we are just entering the second wave of influenza in this country. Next slide.
And Dr. Poland, for everybody's benefit, SARS-CoV-2 is the same, or the core that drives the disease that people have read about as COVID-19. Is that right? In the coronavirus?
Yeah, we'll go over that nosology as we progress.
Thank you.
So as we were saying, the name of the virus is SARS-CoV-2. The name of the disease that the virus causes is COVID-19. corona is just a Latin term referring to the crown-like appearance of what's called the S-spike proteins on the surface of the virus, and to whoever named it, that looked like a crown, so they called it coronavirus. Next slide. Well, these coronaviruses are really zoonoses. That is, they emanate from other animals, and where that ecologic niche is bats. Bats have the greatest diversity, over 500 known coronaviruses, and those pass from bats to humans, or more often to another mammalian species. And one thing that's interesting is because of the power of the new biology and genetic sequencing, you can actually trace back and guess when the virus emerged based on the number of mutations that it has accumulated. So Netherlands 63 strain, probably way back in the 1100s, SARS in 2003, MERS in 2012, and now SARS-CoV-2 in probably October of 2019. Next slide. Can we go to the next? So how contagious is this virus? Again, I think this is important in terms of thinking about this and framing our responses. I like to say that other than fear and ignorance, which is the most contagious disease in humans, measles is next, and that's a virus I've studied for some 30 years. Even though we have a safe and effective vaccine, can't get people to take it, still have continuing outbreaks. If you look at this novel new coronavirus, it's down around where influenza is. Next slide. So how do humans get infected? Well, there are multiple methods, but the most important one is inhalation of viral-laden respiratory droplets. The second is touching contaminated surfaces. Next, any kind of close contact, like touching surfaces that others have touched, kissing, handshaking, etc. We know the virus can be excreted by some people in stool, and so the oral fecal route, much like the disease we saw in 2002 called SARS, was also transmitted that way. And speculation, but maybe eating infected animal material. Next slide. Typical symptoms of a coronavirus infection are listed here. The main thing you'll notice is that they overlap exactly with influenza. So the number one to do on your list, if you and your family have not gotten flu vaccine, is get a flu vaccine. If you don't bother to get a flu vaccine and you get coronavirus, don't talk to me. I warned you. And the reason for it is we're anticipating with this second wave of flu a tsunami of demand that cannot be met and is going to cause a lot of angst and concern among people. We're hearing a lot of background noise. I don't know if somebody could mute potentially. So fever, cough, shortness of breath, and muscle aches. Next slide. Well, what about clinical severity? Well, these are the first 44,000 cases. And it's important to note that the vast majority, 80%, are going to have mild or no symptoms at all. This is particularly true among kids. 14% have more severe disease, 5% critical illness, and a case fatality rate of about 2.3%. We'll see later that that high rate has not held up in the US. The joint WHO-China fact-finding mission noted that the majority of these critical and fatal cases were in people who were in advanced age. By the way, they define that as over 50 to 60 years old, or who had underlying medical issues. Next slide. So here's by age what that case fatality rate. You notice the extreme mortality in people over the age of 80. Now look at people under the age of 40, 0.2. In the US so far, that mortality rate has been 0.03%. So again, let's take this disease seriously. I'm not diminishing its importance, but let's not panic either. Next slide.
Dr. Poland, just a brief question. On the mortality rates that you noted here for China, and when you said the US rate was, did you say 0.03 or 0.02?
No, 0.03.
Right, 0.03. On that, is that similar to influenza or even lower than?
Yeah, no, right around influenza for elderly people.
Okay, thank you.
Next slide. So this is what a sneeze looks like. These are the viral laden particles. They get accelerated by about 150 miles an hour. They spread out in a cloud or a plume. What you can't see here is the much larger plume of the aerosolized virus. What you're seeing is mucus. And this is the issue with people sneezing and coughing. No one thinks their germs are important causes of disease. And they sneeze into their hand and then shake your hand or touch a surface like a doorknob that then the next person comes behind and touches. And this is how these disease gets transmitted. Next slide. The other area where this occurs, and I call this the most dangerous room in any facility, is the public washroom. Understand, when you got to go, you got to go. But you have the most number of people in a day crowd into the smallest room in the facility, and two things happen. Number one, I have never, ever, ever, let me just be clear, never, ever seen a layperson wash their hands properly. And when you go into a washroom, the consequence of that gets exacerbated. Every surface in a bathroom is grossly contaminated with bacteria and viruses because of what's called the toilet cloud plume. So when you flush a toilet, particularly when the cover is not down, all of that, any virus there gets aerosolized and can be cultured off the surfaces. Similarly with warm air dryers, that also effectively blows virus all through that room. So personal opinion here is I would not use these dryers during a time of pandemic. I would have paper towels in there. I would teach people you don't touch the water faucet knobs. I have cultured them myself. They are grossly contaminated with fecal bacteria, so much so that the bacterial load is lower if you were to wash your hands in the toilet than to touch the knobs. And then you egress the bathroom using a paper towel and not touching the door handle. Next slide.
To be clear, you're not suggesting that we actually should go wash our hands in the toilet.
Correct. So an environmental study of a room of a patient who had mild symptomatic COVID-19. We could detect viral RNA on every surface in that room. Importantly, routine cleaning, and I'll go over that later, routine cleaning eliminated that virus. And it's just to note that viral RNA detection doesn't necessarily mean that it's infectious, but it's a good indicator of it. Next slide. So I've often asked, how long does the virus persist on surfaces? I won't read this to you, but it is based on what kind of surface, the inoculum, that is the amount of virus, the ambient temperature, and then you can understand duration. So you can see there that we have MERS, human coronaviruses, and SARS, and they last anywhere on aluminum 2 to 8 hours to as long as 6 to 9 days on plastics and on fabrics. So a considerable period of time, longer than most people usually realize. Next slide. So this is a very quick overview of 22 studies that looked at persistence on surfaces and how they could be inactivated. A cleaner that has at least 60 to 70% alcohol, or 0.5% hydrogen peroxide, or dilute bleach solutions or povidone iodine are all very effective. This is a lipid envelope virus. It's killed very easily. Other agents that are commonly used, and some of the disinfectants may only have these, are not as effective. You can find this on the EPA website if you have questions. Next slide. Well, I mentioned the real human behavior problem that we're having, and that is everyone thinks they know how to wash their hands. And I don't know if I can really convince you, but nobody actually knows how to do it. Besides infection prevention professionals and surgeons, nobody does it properly. Go to YouTube, not now, and search for Dr. Poland and Jimmy Kimmel, and we show you how to wash your hands using a substance we put on hands that glows under black light, and we show people how poorly they actually wash their hands. Basic rule of thumb, really hard to do, and I didn't mean that as a pun, but I just realized it. Don't touch your face or eat until you've washed your hands properly. A second best is hand sanitizer. Nobody does that right either. It has to be at least 60 to 70% alcohol based. Doesn't work well if the hands are visibly soiled or have mucus. You need at least a quarter to a $half dollop size of it. You rub it the same way I show you on the video with hand washing, including the fingertips, and you keep rubbing until it's dry. You keep rubbing until it's dry. Next slide. So what can you do? What can you teach kids? What can you communicate? These are better than an antiviral, and yet we can't get people to reliably do them. Wash your hands the proper way. Don't touch your face. Cover your cough or sneeze with a tissue, throw the tissue away, go back to stage one, wash your hands. Don't go to school or work when you're sick. Insist that others follow that same policy. Maintain your distance from people who are ill. Clean and disinfect surfaces that are publicly and regularly touched, and stay home. Next slide. So what should schools do? Let's go to our next slide. Next slide. I think some principles. Children are important vectors in very efficiently transmitting viral illnesses throughout the community. They are why we have, in part, influenza epidemics every year. Studies have been done where if you just immunize children with flu, you don't see flu in the rest of the community. The children themselves are very likely to be asymptomatic or be so mildly symptomatic that in any other season, you might have said, oh, you got a little cold. And schools are mixing vessels that accelerate disease transmission through communities. So the goal is to reduce transmission within the school and thereby the community. This is why you will often see state departments of health prolong vacations, for example, in an influenza pandemic, or close schools in an attempt to decrease community transmission. Next slide. So what would preparedness look like? Well, one is, and let me just make a parenthetical comment. It's really interesting to me as I talk to people nationally and internationally. It seems we have two sorts. People with a real laissez-faire attitude who think, this is nothing, it's the flu, we don't have to do anything, to people who are panicked. Wisdom resides in holding the proper tension between the two. So reviewing and updating preparedness plans before you're in the limelight. A communication plan, and we'll talk about what that means for each of these. An emergency operations plan, environmental cleaning plans, distance or teleteaching plans, and hand hygiene plans, teaching the students, monitoring that they do it. Next slide. Other preparations, monitoring, having a method by which you can monitor absenteeism, and for goodness sake, discontinue attendance awards. Those are perverse incentives for sick kids to come to school. Determine what your SOP is going to be if somebody on campus, a kid, a staff member, whatever, gets ill. End of the day environmental cleaning, and in the Q&A we can talk about what that means. Proper disinfection for commonly touched surfaces. A no handshake, no hug, no touch, no kiss policy. And a strict, if ill, no school attendance policy. Next slide.
As we move to the next slide, I just want to interject here that on the school attendance policy, that's about physical appearance at school. But for a lot of the charter schools out there, even if not already there, we have the ability to engage in some kind of distance or remote learning protocol using and leveraging technology. And in that way, learning can continue and school engagement to the extent a student is healthy enough to still participate.
Yeah. Next slide. Other things I would consider is suspending school travel programs. Schools are not expected to screen in some other way for COVID-19. Share printed information. I mean, you can't communicate enough. And something that has come up that you need to be aware of is bullying and discrimination against persons of Asian ancestry, and trying to be proactive in preventing that. Next slide. Who are you communicating with? Well, it's teachers, it's parents, students, employees. Don't forget the community. There may be others in your circle that you need to communicate with, whether it's boards or something like that. The principle here is inform, educate, and demonstrate by what you're doing and how you're communicating that you're a highly responsible member of the community. And just to parenthetically say, even in the context of a healthcare institution, what we learn is you can't do this enough. You might think 3 times is enough, and the marketers will tell you 7 times. It probably has to be 7 times 7 in order to effectively get the rapidly changing information and framing it that we're doing this real time, expect real-time updates and potentially changes in information based on what we know. Next slide. So what's effective? We know that education and information is helpful. Hand hygiene and teaching it, having liberal amounts of hand sanitizer stations. You go out for recess, you don't come into the facility without hand sanitizing. You come in the morning, nobody enters without hand sanitizing. Right before lunch, hand sanitize or wash. Appropriate environmental cleaning, and again, we'll talk about that. Respiratory etiquette we've talked about. Avoiding large gatherings, school assemblies, school trips, whatever that might be in your context. And again, staying home when ill. Next slide. Now, school closures. There are 2 postures here, just to mention them, what are called reactive school closures and proactive. Reactive is defined as a case or exposure in the school. This generally implies transmission has already occurred. So even though you might not see that we're having absenteeism or kids that are sick, once you start having it in the community, transmission has already occurred, and school closure is known to be effective in reducing and slowing down that transmission. Proactive is when no case or exposure has occurred. This is more controversial. It is disruptive in a number of ways. And I think each administrator will simply have to weigh the benefits and harms. Next slide. Again, I'm sorry, a lot of background noise. So my summary is, if I could get it out in 3 words, facts, not fears. The majority will have no or very mild symptoms. The issue is spread to older adults or those people of any age who have comorbidities. What do those imply? For example, common one in the school setting, asthma. Those kids are at greater risk. Smokers are at greatly increased risk. Obesity is a chronic immunosuppressive disease. They're at risk. While we haven't seen it yet, pregnancy is usually a risk for any respiratory pathogen. I would say engage, and we're getting ready to publish this, engage in what I call contextually appropriate layers of protection. A way I like to frame it is this. Think about what COVID-19 in your school or community would be like. What would, if you knew that was going to happen, what would you be willing to do to have prevented it? Next, communicate this to people. Get a flu vaccine if you haven't gotten it. This is number 1, 2, and 3 on your priority list for today. Get a flu vaccine. And then be prepared. I hear people talk about, not only politicians, of hope being a plan. It's not. Be prepared and communicate, communicate, communicate. Next slide. I list some resources there. These are ones that I have found helpful in directing people. CDC has a very nice website. It has an FAQ for school administrators, materials for parents, materials for educating students. It's very well done. Your state health department, and if you're in a smaller state, maybe go to the website of larger states. New York City in particular, I thought had excellent materials. The NEA has a website with very good materials, US DOE also. And if you're not aware of the Readiness and Emergency Management for Schools Technical Assistance Center, I think they're doing a very good job of trying to communicate, and would commend that site to you. Next slide. Well, I wanted to leave you with my 2 rules for success. Next slide. The first one is never tell everything you know. Next slide. Next slide. And I want to leave you the way I started. Albert Camus saying, everybody knows that pestilences have a way of recurring in the world, and yet somehow we find it hard to believe in ones that crash down on our heads from a blue sky. There have been as many plagues as wars in history, he says, yet always plagues and wars take people equally by surprise. Next slide. I want to thank you for being attentive listeners. Stuart, I'll hand it over to you, and I'd like to do as many Q&As as we can to be as helpful as I can.
Well, we have quite a few questions, and I'll start with, as you've gone through this first, I think it's a very comprehensive overview of the challenges affecting schools and our leaders. With that, the first question we have is, what's the recommended length of time for a school closure, whether it's proactive or reactive, if caught very early on?
Yeah, that's an insightful question. No one actually knows the answer to that because incubation periods for the virus can be quite variable. You will, if school closures occur, you will undoubtedly get direction from your state health department. But in general, what we would want to do is to be closed for at least a minimum of 14 days after the last identified case, because people can incubate the virus for that long.
And then recently, as you talked about proactive versus reactive school closure, as of this morning, there are 7 states in the U.S. that have closed public and private schools by governmental decision. as that happens, the rest of the country has not necessarily gone there, but is it given the trade-offs? I think we're moving very rapidly this period of dealing with the school closure. What are your thoughts about the prevention for kids out of school, really, of the slowdown of the disease's path?
Yeah.
And
Well, it definitely has been shown to be effective under some conditions. In the US, and depends on where you live, but let's just take a suburban or urban area. You take all the kids out of school, guess what they do? They congregate anyway in the malls or other places. So if you can prevent that, it is effective in slowing down transmission. Why is that important? If no one knows, this is speculative, but if SARS-CoV-2 acts the way SARS-CoV did, then what we saw is by June of 2003, we saw that dampen down and disappear. So the idea is, will this virus, like other seasonal coronaviruses, if we can delay it out towards spring and the warmer weathers and windows open, will we dampen down the transmission and have it disappear? No one knows, but that's the idea.
what was the most recent that time frame that you mentioned on the previous SARS outbreak?
SARS was recognized in November of 2002 and ended in the June-July 2003 timeframe. Now, MERS, another novel coronavirus, did not disappear, still circulating and causing small outbreaks. By the way, it's worth noting, just so that people have the proper context, if I asked you how many of you have been infected with coronavirus, if you were knowledgeable about this, and no one expects that you would have been, but all of you have been infected with coronaviruses multiple times, multiple years, and that's because there are 4 endemically circulating coronaviruses that cause about 30% or so of wintertime colds.
Well, one question we have here is, why is it so important, your emphasis on getting a flu shot at what's perceived as at this late date, at this, given where we're at in the process? And I guess I'd say for some it seems very early and for others late, but why get a flu shot now in March, post what is the normal flu season?
Yeah, well, so that is a misconception. So the peak of our flu seasons in the US tend to be in February and March. So it's not late at all. It's not too late. Multiple reasons to get a flu shot. Number one, we're just starting a second wave of H1N1 influenza in this country. It's already taken 30,000 lives, and I was just checking the latest number. It's 154 kids have died in the last 4 months from flu, and we're starting a second wave. So that's one reason. Second reason is because of the prevalence of the virus, the worst thing to have happen is to be co-infected. So now we've just decreased your odds of, or rather increased your odds of having complicated disease or a fatal case if you're infected with 2 respiratory pathogens that can cause severe disease. Third, we're very concerned about what will be a surge demand on the medical system. People won't take SARS-CoV-2 seriously. Then they get, I've got a fever, a sore throat, and a cough. They're demanding attention. They want to get tested. They're concerned out of their mind over what to do, and it turns out to be flu. We could take a whole swath of that off our plate if people would get flu vaccine.
As you talk about the comparison to the flu, and it sounds like one question that we had here you've already answered, which is you could be infected with 2 types of coronavirus, the COVID-19 and influenza at the same time. And those would be 2 strains of virus really impacting your system. Is that
Absolutely. Yes, absolutely.
And one of the things, again, comparing this, just because people have more experience in the past with the flu, is we've heard a lot about the incubation period potentially for COVID-19 being longer than influenza. How does this impact the spread? Well, first, is that true? Is the incubation period actually longer before one might know about that they have it?
It's longer.
How much?
It's longer for SARS-CoV-2 than it is for influenza, definitely. Both of them can be spread before you develop symptoms. And that's the hard part of it. And that's why you begin to engage in maneuvers that are disruptive, like school closings, et cetera, because a case is the tip of the iceberg. That's one sick enough to come to attention. Unless that happened to be, well, they were in Italy, they developed the disease. Once you have a second generation, a community case, then you know the virus is circulating in the community.
So we've heard a lot about recently, and you compared these different reactions, but an example recently is the self-quarantining, or as you've gone through this material today, if you're sick, stay home, or if you've been exposed, stay home. How does self-quarantine really work? What does that mean? Is it just stay home, or is it don't answer the door, don't go outside? Can you talk a little bit about that and what impact that has in assisting the community?
Wow. So this is why we use this term contextually appropriate layers of protection. Let me build the analogy. Let's just assume most of us maybe live in a suburban setting. Well, what that means is to prevent crime at night, you probably lock your front and back door. You probably close your first floor windows, and maybe you flip a light on. 3 layers of protection. You live in, I don't know, maybe a more difficult inner city situation or a place that's had higher rates of crime. You probably do those, and then you add additional layers of protection, maybe an alarm system, maybe window bars, maybe a panic button. For some people, maybe even a weapon in their home. They're adding 5, 6 layers of protection. And that's why I want to be careful to not just give black and white answers here. It has to be contextually appropriate. So if you're immunocompromised, if you have comorbidities that are likely to lead to complicated illness, logically, you would layer more layers of protection around you than me or maybe many of the listeners. So if you're in that position, and if you're in then home isolation or self-quarantine, you have to think through how many layers at what cost to my life. So that means if you're sick, then you're at home in a room, not exposing others in the home, with an open window, regular disinfection of any surfaces that you've touched. You don't come out of the room without a mask on, and you don't let others into the home. If it's, well, the government has said we should stay home and self-isolate, well, then you have to figure out in the context of your life, what does that mean? It means avoiding large crowds. It means not having people over to your home. It means being prepared in your own home with a 30-day supply of prescription medicines or other medicines that you need. It means having food and water and other things you may need. Think through, what would you need to live in your home for 30 days? It's all of that you have to think through.
That's as we've seen, as you've gone through this, very helpful context. A lot of our schools are dealing with challenges around activities like sports activities or other community activities, gatherings, etc. I wonder if you can talk about campus events, and things like that. In the context of recently, for instance, the NCAA and in
Right.
fact, professional sports leagues canceling sports activities versus playing the events with no audiences.
Yeah. My personal opinion is that given the risk and given the optics, that's different. So optics are different than science, okay? And each administrator will have to think about the optics in their community. You don't want to be that school that everybody points to and blames for the outbreak. So we're talking science and we're talking optics here. My personal opinion is that when you have groups of kids gathered, you have quantifiably increased risk. How high is context dependent? I can't give a black and white answer to that. And is it really necessary to play that sports game in the context of an ongoing pandemic? I would say for the most part, no. And that's something to me easier to cancel.
How does a staff leader or how does a principal or school leader deal with things? And I think this applies to corporate environments also. How do we react to a staff member who may actually be symptomatic, but given that the symptoms are the same as the flu or very similar, but has not traveled or had and given the current environment, medical professionals have not yet tested for COVID-19. What is it we do in that situation?
Yeah, and that's again the reason to be getting a flu shot is to take away that whole larger, much larger risk of influenza away from this discussion. CDC does on their website, by the way, have guidelines for people with febrile illnesses on campuses versus no such cases in the school yet. But in general, when you, in the context of a pandemic, when you have somebody with a cough, febrile illness, they don't come on campus.
But that carries further somebody who has been exposed to somebody with those symptoms. At this point, are you suggesting that those people also don't come on campus, or it's even though you're being that period for your asymptomatic?
Yeah, that's the tougher and more disruptive one, right? But if you were exposed to somebody who we know had COVID-19, for sure, you're in home isolation, you're not on campus. After that, it gets harder to know what to do. But again, I think a little bit of the science and a lot more of the optics are if you had close exposure, that's 5 to 10 minutes or more, closer than 5 feet with somebody who has a febrile illness, you're at risk. And therefore you are a potential transmitter to others.
Let's go further with that. In terms of different groups that may be more affected, either in terms of contracting this disease or its impact on them, I'll describe a couple of examples here. You mentioned pregnant women. We'll get into that, I think, in a bit about what additional precautions might be taken. We have another example of people who may have only one healthy kidney, but no other underlying issues. There are people who may be cancer survivors, but not actively with radiation or ongoing treatment. And there are also rumors, I guess I'll put it, in the community of children are less likely to contract and as you noted, maybe are not as severely impacted by the disease itself. Can you speak to some of those different groups, the
Sure.
pregnancy, cancer survivors, a healthy kidney, but
So of course, I can't speak to every medical condition, but let me give you the
Of
big
course.
ones. So somebody who is a quote cancer survivor has recovered their immune system are at no more risk than anybody else their age. Somebody otherwise healthy with a single kidney at no more risk than anybody else their age. So what are the risks? Well, I mentioned, and let's just take China where this data came out of. Their overall case fatality rate in China, in Wuhan, was 2.3%. If you had cardiovascular disease, 10.5%. If you had diabetes, 7%. Respiratory disease like asthma, COPD, smoker, 6%. Hypertension, 6%. Now, the data on pregnancy are more difficult. There have only been 18 known women infected with SARS-CoV-2, only 2 small studies. None of those women passed the virus on to their babies. That doesn't mean the babies didn't subsequently get infected. One baby got infected 17 days later because the secondary caretaker of the baby developed disease. But surprisingly so far, no data. Now, influenza in a pregnant woman, deadly. That's why we push and push and push to try to get pregnant women to get their flu vaccine. So what special precautions would I take for a pregnant woman? Well, they are at higher risk of contracting the disease if they're a teacher, just because they're around kids. That's true for all respiratory pathogens. I would say to them, and I'd have a conversation, we call it shared decision making. I would say what little data there are right now don't show any elevated risk. Nonetheless, I would work off the precautionary principle with not being around sick kids, regular disinfection of surfaces, strict hand washing, strict social distancing, etc.
You mentioned the disinfection, and we hear sometimes the term deep cleaning. What does that really mean, deep clean? Earlier in the discussion today, you mentioned a number of different disinfectants that are useful. They don't sound like a particular deep cleaning to me, but what's a deep clean versus any other form of cleaning the environment, and if there is such a thing, what is it that we need to deep clean?
Yeah, deep clean is a term I don't like. I think it's a kind of a PR word rather than just to say to sanitize or disinfect. The term is used by people when they talk about a known case or somebody who's sick. And if I ever use that term, what I would mean by that is that you're disinfecting the entire room rather than just disinfecting floor, handrails, doorknobs, the publicly touched surfaces. So what does that mean? A deep quote unquote clean is you're cleaning walls, ceilings, basically everything in the room because there's been an active case of COVID-19 in that room. If that's not the case, then you're just doing precautionary disinfection of surfaces that you're likely to touch. You're not likely to touch the ceiling, so no reason to clean it in a precautionary stance.
If there's in our households, if one person living in the household or in the environment gets COVID-19, how likely is it that everybody gets it?
That's a really good question, Stuart. So the early studies showed that the transmission among family members was 3 to 10%. Surprisingly low. I'm not sure I believe those data. We are, for many of these questions, let me just back up and say, because the analogy I think is useful. If you've ever seen pixelated photographs, the first 20–30% of pixels are put up on the canvas. It just looks like a mess. You don't know what it is. You get to 50–70% of the pixels and you begin to say, looks like a picture of something. You get to 80–90%, you go, oh, that's a picture of George Washington. We are, for many of these things, back in the 30–50% pixelation. So it's hard to know this, and I think intra-family transmission is one of those. Obviously a high-risk situation because you've got the presence of virus, but how extensive that is, don't know yet.
If we see members of the community, staff, or kids at school who are coughing as the only symptom they seem to have, should we be sending them home? Do we send everybody home with any of these symptoms, even though it's not fever or what have you, in this environment?
That's the tough part, isn't it? Because it's not like you have medical professionals there that can evaluate thoroughly each child. Coughing can be because of asthma. It can be anxiety. It can be a whole lot of things that aren't infection. So again, it's context dependent, but where we're concerned is if somebody has a cough and fever, because at least with COVID-19, they are so common together. Are there cases that cough that don't have fever? Yeah. Are there people that have fever that don't have cough? Yeah. But how are you going to deal with it? You're trying to take a population level approach. So if this is a kid coughing that normally isn't a cougher from asthma or from irritants, allergies, something like that, and they're coughing and don't normally cough, I would say that person needs to leave school until they're evaluated. I don't know if that helps, but.
Yeah, I think as you're noting, it's a balance, right? Everybody can go to their own 6-foot bubble and walk around. We could do that, but humanity would kind of grind to a halt.
Yeah.
And that challenge or making that trade-off is something to consider and balance. Given that we're in communities, right, and you're in these environments, should students or members of the school community be wiping down desks or work tables with, Clorox wipes every day or several times a day, or should we all be walking around with a little wipe for every doorknob we grab? How should we think about how often to clean?
Yeah. So at a minimum, at the end of the day, the regularly touched surfaces get wiped down. How often to do that above and beyond that, I think, again, depends on context, availability, personnel to do it. If they're going to do it, they need to wipe it down with gloves on, not with their bare hands. If there's an actual case and you're trying to clean a room, that's not something that a teacher is trained to do. You need people who are in gowns, masks, and gloves to clean and wipe down. But nobody knows. Nobody can tell you, because nobody knows how many times somebody touches that doorknob or who's sick or who isn't. Nobody can tell you, well, yeah, do it every 13.4 minutes. No one can give you that data. What's best? Well, I think what's feasible to do, absent a case, would be that everybody knows how to wash their hands. You've got a lineup of hand sanitizer dispensing stations so that no one comes into the school without hand sanitizing. No one goes into lunch or a snack or something like that without washing their hands. If they're all in the lunchroom together, they sanitize when they leave the lunchroom and go to their classrooms. What you'll have to go through your school and decide what gets touched. Yeah, my guess is it's the door handles coming in and going out of the school, door handles in and out of the classrooms, door handles in and out of the bathrooms. Those I would wipe down. And ideally, if you could do it several times a day, so much the better. These are, let's recognize, being done out of an abundance of caution.
What sort of supplies should we, it sounds like, maintain in the home generally, or in our homes or around campus, beyond, if there is, beyond just the hand sanitizers, which are in short supply in some places, around the school, as you mentioned? Any other things that we should
Stuart, I
keep
didn't
around?
understand. Are you saying at home or at school?
I think in either place. If they're different, sure.
Okay.
But I think this is, go ahead.
They're definitely different. Home, you not only have the prevention of infection, but the maintenance of health issues to look after: food, water, prescription medicines, anything that when you sit and you look around your home, you say, we would need this to be able to survive for 30 days. Now, this is not a new recommendation. CDC has been making this recommendation for 20 years now, since Y2K, that everybody have the ability to live in their home for 30 days without outside resourcing. So I think that's important to think about. You may be interested that there are some religious communities, including within in the U.S., that maintain stocks for 1 to 2 years of independent living. I'm not advocating that, but a 30-day supply. Now, in schools, you're not worried about the individual maintenance of health, how we live, how we wash things, how we eat. You are worried about prevention of transmission. And so what you're going to do is layered around that principle. What do you need? You need to have cleanup equipment. You need to have an SOP of what you're going to do if somebody is febrile and sick and subsequently confirmed to have COVID-19. What are you going to do? What are you going to do in terms of exclusionary policies for visitors, staff, delivery people, kids, etc., that are that may be ill or become ill? You need to have an adequate supply of disinfectant solutions to be able to do wipe downs, mopping, etc. You need gloves, but you don't need masks, you don't need gowns. That's something that a more specialized company would bring to bear.
Are there any over-the-counter medications that a person can take if you contract COVID-19? And does that change if you have somebody who's got some of these other weakened immunocompromised states like diabetes or cardiac situations that you described earlier?
Yeah, no, I mean, those are treated by medication. In terms of, and I suspect that the questioner might be getting toward the sacred issue of supplements and herbs, and my aunt told me this, or I read on the internet that zinc does that, or vitamin C. None of them, zero, none of them have been shown to be helpful in this particular disease. Now, in some cases, that's because they haven't been studied, but they have been studied with other respiratory pathogens, and they're just not helpful. And some of them are potentially harmful. Remember that these are not substances that are FDA regulated. We have done at Mayo Clinic various studies. You may remember that for a while, amino acid supplements for fatigue were common. Well, we found some that had no active ingredient whatsoever, some that had minute doses, and some that were grossly contaminated. And you may remember a small outbreak where one of them was contaminated with a substance that caused people to lose the ability to breathe on their own. and now live their lives on ventilators if they survived. So I'm not a fan at all of unregulated, untested supplements. Maybe something worth having in your home for comfort sake and treatment sake is Tylenol. That's about it. Even the over-the-counter cold remedies, when they are studied, have no significant value.
That's very helpful. I think as we think about things coming up, and I'm sensitive to the time that we plan for, and for your very valuable time, that as we go beyond the disease, one thing from that people have expressed as, this may be real or fear, as members of our staff or families or students, to the extent they've traveled to cities and countries or countries recently that have high COVID-19 rates, should we be maintaining in our schools or communities our own sort of, hey, you need to self-quarantine, as though somebody were on a cruise or something like that? If you were in a locale that just has higher concentration or incidence of the disease, should we just say stay at home for a couple of weeks, or what is your thought on that?
You know, you have to check, each one will have to check with, you know, legal or HR on this, but the recommendation would be is that if you have been in or transited through a high risk area, I personally would be in favor of that person has to be in quarantine for 14 days until we have data that would suggest differently. Many organizations are going to no travel bans. I'm under a no travel ban. I am not allowed to meet in groups larger than 10, and most of our meetings now are virtual. Now my context is different than your content, but just to be aware of what other businesses are doing. I work, I'm the editor of a journal, and it's a very large organization. They've suspended all in-person operations and are doing everything virtually. So you need to think through and have a potential plan for that. I personally think that it's appropriate for staff to be under a no travel ban. I personally think it's appropriate that if parents and kids are going to go on spring breaks to places that are of known high risk, that they would be banned from campus for 14 days. Those are all the sorts of things you have to think through, and you can get a lot of detailed information on this, again, from the resources that I listed there.
I want to let everybody know, as we bring this to a close today, that we mentioned earlier in the presentation that there was an upcoming webinar next week regarding communication plans and many of the things that Dr. Poland has discussed today, but now getting tactical about plans, communication policies, et cetera, and managing that community environment. And we mentioned that that was coming up. That will be next Friday, March 20th. In the material here, it said March 17th, and I think that was just some of our team here already yearning for and preparing for St. Patrick's Day, maybe in fact prematurely participating in some of the celebration of St. Patrick's Day. That said, we will have a communication and school management challenges webinar next Friday, the 20th, and more information will go out about that. I want to say it's been such a privilege for me, Dr. Poland, to listen to you today and walk through this. And I can see from the activity we had and the number of questions that came through during your discussion that the community at large and the charter school movement is really seeking all this information and was very actively involved today. And I can't thank you enough for taking your time to let us know.
Yeah, thank you. Thank you very much. It was a pleasure to work with the Charter School Capital staff in getting this organized. They did a spectacular job. Great questions from the listeners. I'd be happy to come back and, maybe in the interim, in between what you have planned, doing maybe a full Q&A session or something, and help direct people to resources, because you guys, what you do is important to a nation, and I want to be able to support that as best I can.
Well, as a founder and supporter of charter schools in your life, we really appreciate that, and we'll be sure to take advantage of your offer in the coming weeks. Thank you again for your time today, and thank you everybody who was able to join today with Dr. Greg Poland of the Mayo Clinic. And with that, I'm Stuart Ellis, and we at Charter School Capital thank you all for joining us today. And as Dr. Poland mentioned, he is and we are here to support you as you face these challenges going forward.
Thank you, and good luck to all.
Thank you.
Stay well.